This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hello friends, this is a 5-year-old girl who has sustained a blunt injury to the right eye and she has this traumatic cataract and she's posted for surgery. Now this is the clinical picture on the table. The patient is under IV sedation and this is how the eye looks. The pupil is refusing to dilate, it has a festooned appearance, and in the center there seems to be a fibrotic inflammatory band along which we can see these posterior synechiae. Now how do we approach this case? I would want all of you to just take a pen and a paper and write down what are the things that are crossing in your mind and how are you going to plan surgery for this young child. So let me begin with the thoughts which are there running in my head. So I want to find out what is the reason for this inflammatory band and the posterior synechiae. In such situations, I always would like to look for any rupture in the anterior capsule. So as I look closely, behind this fibrotic inflamed membrane, I am suspecting a split anterior capsule. And whenever the lens material is exposed, that's the reason why the inflammation sets in, and that is the reason why we have the posterior synechiae and also the inflamed fibrotic band. So I'm very certain that the anterior capsule split is there underneath this posterior synechiae. So that's the first observation one has to make. Then now we have to plan the surgery. Once I've figured out that the anterior capsule is ruptured, then my goal would be to ensure that I should have some amount of anterior capsule support remaining so that I can place the lens into the bag itself. At this stage, I'm not sure whether the posterior capsule is intact or there is a pre-existing tear. With all of these points in mind, my first goal would be to ensure that I do a limited capsulotomy on either side so that some amount of anterior capsular support is there, then evacuate the lens matter and then place the lens in the bag itself. However, in the worst case scenario, when there is a pre-existing PC tear, I'm also ready with my anti-vitrectomy unit and a sterile cutter and also a multi-piece lens to be placed in the sulcus in the worst case scenario. So let's begin. The two side ports are first created. The anterior capsule is stained under the cover of the air bubble. The stain is washed off. Then I'm going to inject a dispersive OVD into the anterior chamber. Care is taken not to inject in the presumed area of capsular split because that's going to enlarge it and might risk of running across the periphery into the posterior capsule as well. I'm sitting temporarily and the main 2.8mm incision is created. Care is to be taken that I have got enough corneal valve so that the wound is perfectly self-sealing at the end of the surgery. My first plan is to somehow separate the posterior synechiae so that I can see well what is underlying. So I'm using a blunt micro iris spatula to introduce it under the iris, and then I'm just passing it below the iris so that the posterior synechiae is broken off. Similar maneuver is done on the other side. Care is to be taken that we need to be very gentle. Very aggressive pulling or tugging at the iris can result in iridodialysis at the root. So we need to be conscious. Just be a little bit gentle and we'll be successful in separating it out. So once the posterior synechiae is separated, the pupil is much wider and we can see things very clearly. It's very obvious now that the underlying anterior capsular split is staring at me. So the first thing to do now is to enlarge the anterior capsular opening. So I'm using my Senscuke to stabilize the globe with my second instrument. I'm using a micro scissors through the main incision to give a nick to the anterior capsule starting from the central split. With the same scissors, the other half of the capsular split, a small nick is also given into it. Chamber is refilled with OVD. So using the Rexis forceps, I'm catching hold of this flap and then gently trying to tear it. Some part of the capsule is fibrotic and I'm finding it difficult to tear. At the same time, also concerned that it shouldn't run away. Carefully but surely tear the capsule until I reach the other end of the split. So we have a C-shaped opening in the left side of the anterior capsule. OVD is refilled into the chamber. Because I want to maintain the chamber, I don't want the capsulotomy tear to extend onto the equator. There's a reason I want to replenish the OVD at every stage. The small fibrotic band which is refusing to tear at the distal end is cut by the help of the scissors. I'm trying to pull out this half of the capsule but it's refusing to come because of the underlying fibrotic membrane. Again, I go in and cut the fibrotic membrane with the help of this micro scissors and eventually I could pull this part of the capsule out. The second part of the tearing of the anterior capsule is done. And again, we have a C-shaped opening in the right side of the capsule as well. Again, the peripheral edge is refusing to tear because of the fibrotic nature. I'm going in with my micro scissors through the side port and just to cut it off. The distal portion of the small fibrotic capsule is again held with the forceps in the left hand, and then using the scissors it is cut. So now the torn anterior capsule is taken out completely. So we have a sort of C-shaped anterior capsule opening present on either side. Now is the time to go ahead and do the lens matter aspiration. Now this is the easier part. So in young children, the lens matter is pretty soft. So even 22G aspiration cannula is good enough to aspirate all the lens matter. Few cortical fibers are remaining, and I'm just trying to engage each one of them and aspirate it out. Before switching hands, I don't want the chamber to shallow, so I go in and inject OVD into the eye and then remove the irrigation handpiece. I don't want the peripheral extended tears in the anterior capsule to propagate beyond the equator when the AC suddenly shallows. Especially in these young children who have a very low scleral rigidity, the chances of shallowing of the chamber is pretty high. That's the reason I'm making a conscious attempt to not to lose the chamber by injecting OVD before withdrawing the irrigation handpiece. The hands are switched, and the remaining bit of cortex on the other side beneath the anterior capsule is now being aspirated out. So it's heartening to see that there is no posterior capsular tear. The tear was just limited to the anterior capsule, and it's good to go now. Now since I've got an adequate amount of anterior capsular support, I'm confident enough to place the lens into the bag, so I'm going to go ahead with the single piece hydrophobic lens. So the cortex aspiration is done now. I'm going to refill the chamber with cohesive OVD so that the chamber is maintained well and it doesn't shallow when I'm trying to maneuver the lens into the bag. The distal haptic is first introduced into the capsular bag, followed by the proximal haptic. Both the haptics are then dialed in, and care is taken that the haptics are 90 degrees away from the direction of the anterior capsular split. This ensures that the lens remains centered over a longer period of time. The OVD both in front and behind the lens is removed. The side ports are hydrated. In these young children, it's important that we hydrate the wounds for a little bit longer time because these tissues are much more elastic. And in this event where we're suspecting some wound leak, we can go ahead and put in a suture. But this eye, the wound seems to be watertight, both the side ports as well as the main incision. I wait for a couple of minutes and ensure that the wounds are truly sealed with hydration. So I'm not planning to put any suture. That's it, the case is done. Now these are the pictures of the early post-op period, and the patient is doing pretty fine. Take-home message from this case would be, whenever we're suspecting a posterior synechia or evidence of inflammation, always search for evidence of a ruptured anterior capsule. So in these traumatic cataracts, it's invariable to find pre-existing ruptured anterior capsule, and in few cases a pre-existing posterior capsular tear as well. So being mindful and being well prepared is a key to success in such cases. I hope you found this useful. Thank you for watching.